It's a great honor to be able to chat with you here this afternoon, or I guess still this morning. I will have more to say about the pediatric side of the lifespan than the older side of the lifespan, since I'm basically a pediatric orthopedist and I don't want to oversell myself. I think it typically is better to talk about something you know something about, although not always limited to that. No disclosures, and I'll talk a little about general orthopedic management. So what's the role of orthopedics? And I think this varies a bit about where you're at. I see my role as counseling families, providing support, giving advice on sort of musculoskeletal issues. Our real goal is to prevent and treat bone and muscle deformities and to understand the expected natural development. This is a really big part of the issues and the problems that we need to address to try to maximize the child's function with the least invasive treatment, with the least disruption to the family and the child, and the least impact on the child's education and social development, because all of these are all going on, and the medical management should not overwhelm those. There are different systems, and so you all probably come from systems that are a little different. Some places, orthopedists only see the child when somebody decides surgery is needed. I come from a perspective where I see most of my families and children, or I have in the past, but it's probably not going to happen now. I would see them when they're somewhere between 1 and 2 years of age, and then I typically see them until they're 20. So I am with them for the whole growing up time, but now I've grown up, so that part will unfortunately end. Understanding the child's development is part of what I see my role, trying to follow the child. And again, there are other places where there are more multidisciplinary teams with physical therapists where the orthopedist is not so directly involved. Nevertheless, the goal should be the same. You need someone who can sort of help to direct and understand what is happening. If you're trying to find an orthopedist, if there isn't one that you sort of are familiar with and trying to give advice to families who call me, you should really be looking for a pediatric orthopedist if you have a child. If you're an adult, it's still probably best if you can find a pediatric orthopedist, because there are very few adult orthopedists who have experience with developmental disabilities or with neurologic conditions. Again, the issue of what is your goal. If the goal is to try to make the child walk better, then ideally it should be a facility where there's a gait analysis laboratory. And the physician that you see should be confident and comfortable in discussing with you the expected natural history. What's going to happen? Be comfortable and confident in talking to you about outcomes, what they expect from treatment, and the risks involved. Remember that every treatment has complications and risks. There is nothing you do to a child, from physical therapy and bracing to big surgery, that does not involve some risks. And then I sort of make a pitch for the AACPDM, because orthopedists who are members of this society by nature have an interest in cerebral palsy. So what are the things that I do, or what happens? And for me, the thing that happens, the most common question I get in the young child is, will my child walk? The first thing we have to know is that it's very difficult to make these predictions. Once you have the diagnosis of cerebral palsy, then finding the prediction of what the child will be like 5 and 10 years later is difficult. And I like to use the analogy of weather predicting. You know that if you look outside now, you can be pretty sure what the weather is like now. and maybe for the next 30 minutes. If you turn on the news report, they'll give you a 1-day and a 5-day report, and weather forecasters are pretty good at that. But if you want to find out what will be the weather at Christmas time, if you live in Hollywood, Florida, you can be pretty sure it isn't going to snow, right? If you live in Minnesota, well, it probably is going to be cold. You don't want to sit outside on the beach. But you can't tell whether it'll be a snowy day. It's just not possible. And predicting the child's development with cerebral palsy is very much like that. The further out you want to look, the less predictable it is. We have these old parameters that we still use. If a child is not rolling by 2, or not sitting by 5, or not walking by 8, the prognosis for independent walking is poor. But as you can tell, this means basically you have to wait till they're 8 almost. So that's not very good prediction. One of the problems is that there are no tests that we have to look at this. So I show this picture because most of you can look at this and you see this is an X-ray of a bone, of a femur, and there's a fracture there that all of you can see. And you can be confident if your child was brought to the emergency room with that, people would look at it and they'd come and say, oh, your child has a fractured femur, hurts terrible, your child can't walk on that, we know that. So one of the things you have to sort of understand, especially when you talk to orthopedists, this is what orthopedists are comfortable with. They are comfortable with X-rays that you show, oh, it's a broken bone. We know what that is. It's not maybe a broken bone, it is a broken bone. So then we have a plan. Okay, we know what to do. We know if we don't do this, that, and the other thing, it's not going to work. Cerebral palsy doesn't work like that. That's one of the reasons you find many orthopedists who are not so comfortable with it. Let me give you another example. Scans, and this is a common question I get from families. They say, well, I had a scan of the brain, and the brain didn't show any abnormalities, so therefore the child must be okay, or there's nothing wrong with him. They get that image, but the scans are not very predictive. They're predictive if you take a population, but not on an individual. Let me give you an example here. This scan is almost a normal brain scan. This scan is of a child who has almost no brain. All of his skull is filled up with fluid. These two children, if they were sitting here in front of you, you couldn't tell the difference. They both are the most severe cerebral palsy who require complete care. They cannot communicate. They have no ability to control their muscles. They're blind. They have seizures. And yet, one scan is normal and the other looks very, very bad. Here is a scan that you obviously can tell also has problems because it should look like this. You have a little bit of brain that looks maybe okay, kind of, but it doesn't have the folds. It has a large sac of fluid. This is of a young woman who today has a master's degree in social work. She lives by herself. She walks using a walker. She talks. And she's a fully functioning, independent member of society that I took care of from age 2 to 20, and she still stays in contact with me. This is the problem with these kind of images. So when people are making predictions based on these kind of images, you have to take them with a grain of salt for the individual child, and you have to be comfortable in looking and seeing how the child is doing. Orthopedists sort of tend to talk in these specific patterns of whether it's hemiplegia, one side of the body, diplegia, mainly the legs, or quadriplegia, and then whether the child is spastic or hypotonic or has movement disorders. These things they're sort of blend together. They're not absolutes. So if somebody says one thing and somebody says another, it may not be that they don't know what they're talking about. It just may be that it's this imprecise language that you're getting caught with. There's some newer criteria the GMFCS, which most of you probably know. It's from 1 to 5. If you are a walker, excellent walker, it's 1 to 5 when you're in a wheelchair and no walking ability. But this too has some gray zones. So somebody may say your child is a GMFCS 3 and somebody else says it's a 4. It doesn't mean necessarily those people don't know what they're talking about. It can sort of mean it's part of the impreciseness. There's also this scale for functional motor scale, sort of to give an idea of how individuals walk. That's useful. And we have these nice cartoons to try to put people, and this looks like it's all very absolute. But the problem is that there's tremendous blending. This is not, you're not put in one category. This is a range. People don't come sort of as an absolute one way or the other. The same for the FMS, people sort of vary depending on whether they use a walker or whether they prefer to use crutches based on things not necessarily related to the cerebral palsy. You should be able to get some information from your orthopedist or someone about what happens to a deformity. So you're concerned about a foot, a hip, a back. Somebody should be able to tell you what to expect. That's part of what our role is. And in general, kids get walking better and better until they're about 8 or 9. They plateau, and then they may have a little diminishment. So here's an example of this boy at age 2 is walking with a walker. So the family wants to know, how will he walk when he's 20? Well, I can guarantee them that he will walk, because kids with cerebral palsy never get worse unless there's something that can be corrected. He will not end up in a wheelchair, or he doesn't have cerebral palsy. So we can sort of see, if I can I have trouble here. There we go. So we can see here he is at age 11. And then here he is at age, my mouse is sort of jumpy. Anyhow, there he is at age 15 and below at age 20. So this young man is now graduating from university. He's going into the Foreign Service. He's planning to be a diplomat. He's a very bright young man, walks around campus with a crutch. One crutch. He does not use a wheelchair at all. So that kind of predictions, you can't be specific, but you can say the trend where things are going. Our goal also is to educate, to remember that long-term function is much more dependent on how the child communicates and the cognitive level than if they walk. So if you're in a wheelchair and you're bright and you can communicate and you have good behavior, you have the world open to you. If, on the other hand, you walk but you can't communicate or you have cognitive disabilities, it limits you more. Also, I just want to stress this, that you should expect children to improve. Here's an example of a boy that I followed who then over 2 years, his walking got worse, and here he is at age 9. This is not cerebral palsy. This is another condition, and so if the child has cerebral palsy, you should think of it as a good diagnosis, because it means the child will not get worse. There's some general maybe diminishment as you get to the late teenage and early adulthood, but there's minimum diminishment. A good walker will not stop walking. Remember also that the child with cerebral palsy can have every other condition any normal child can get. So children can get appendicitis. This is a list of diagnoses I have made in our CP clinic, because very commonly the family will be seeing the pediatrician and there's something that's not apparent, and they'll say, go see the orthopedic doctor because there's probably some CP problem. Just be aware. Always think, it's not always the CP. Something else can happen. So when we talk about kids who are in the more severe end, we are trying to keep the children sitting well with good lying posture, having good activities of daily living. The first thing we try to do is keep hips located. Today, the technology is present so that we should almost never see a dislocated hip. In my clinic, over 25 years, I can't remember a child that I followed that ended up with a hip dislocation. It occurs more in the children who don't walk, so it's important to have a monitoring program to get x-rays. And in Sweden, in the whole country of Sweden, since 2002, they have had 2 hip dislocations, and they were both in families who had very severe children. One they thought was going to die, and the other one the family wouldn't follow up with medical care. So we are obligated to pay attention, and the system in the US is pretty fragmented, but we should be able to do that through close clinical monitoring. This is our protocol that's posted in our clinic, so our training residents and fellows can remind themselves and to know what we're looking for, what the schedule is for follow-up. Here's an example of a 3-year-old girl who comes in with a hip on, sometimes my pointer doesn't work. There it is out of the joint. This is also out a little, so we can do a relatively small surgery at this point. And here, 5 years later, when she's 8 years old, she has normal hips. That's our goal. It doesn't always work. Sometimes we have to do bone surgery, hip reconstruction. This is what we don't want to see. We don't want to see these painful, dislocated hips. But even then, we can do reconstruction. These reconstructions by experts in cerebral palsy are very reliable. I am very, very frustrated when I hear some of the parents' experiences with hip surgery. It's not an easy operation. I don't want to say that, but it should have an excellent outcome. And with proper management of spasticity, there's hardly ever a need for casting. This should not be sort of the world's worst experience. This is the outcome of this child's hip at 6 years after surgery. Sometimes it doesn't work because our patients come too late, and then we have to do things like total hip replacements or remove the hip joint. And this really is not an answer because pain continues. They tend to be uncomfortable. It often takes 1 to 2 years for the pain to resolve after you remove the hip joint. It's important to have good seating, so paying attention to wheelchairs. There's the Go Baby Go table in the back. This little car above is the predecessor to that. I was involved with volunteer engineers, and we would get these Toys R Us cars and adapt them for kids. And it's a great way to have kids learn to be mobile and to enjoy play and to be the sort of their neighbors and friends, the envy of their neighbors and friends, to see them whiz around. Sometimes you can't seat a child if there's too long of neglect, and we actually have to do surgery to make the child fit into a wheelchair. Scoliosis is a curvature of the spine. It's very important not to get confused that the idiopathic scoliosis that occurs in girls who are teenagers, this is very different from that. It is a curve that will progressively get worse. Bracing will not impact it. You can use these little braces that are sort of soft wraps. It helps with seating, and it can be useful for that, but it's not going to prevent the scoliosis from getting worse. The only thing that will do that is the surgery, which is a big operation. So this is a boy like a week after his surgery. He has gone from hardly being able to sit to now sitting up straight. This is an example of the rods and the instrumentations that we use. We also can do hand surgery to improve the grip, or sometimes to do some muscle lengthening surgery to help with care if it's hard for dressing. We'll just quickly go through some of the walking. I was talking about an orthopedist, if they are experienced, should be able to give you some ideas of what to expect. Here's a 3-year-old girl who was brought in with a mother and a grandmother very concerned about these very bad-looking feet. In 3-year-olds, I can tell you these feet will get better. It doesn't matter what you do as long as you don't do surgery or anything too dramatic. At age 3, we know they'll get better. I don't know how much better. I know they'll get better in the same way that I know the 80-degree and 90-degree misery we've had in Delaware is going to go away by November. But I don't know what the temperature in November will be. Maybe we'll be freezing and maybe we'll be 70 degrees. So in that same way, these feet will get better. How much, I don't know. Here's this same girl at age 5. She's had one little surgery to lengthen her muscles, but nothing to her feet. This is where she's at age 7. This is natural history. This is part of what you want to be able to understand. If we see the hip dislocating, it's the opposite. The hip will get worse and worse. The scoliosis will get worse and worse. But the feet get better. But at some point, they may not get better, and then they may get worse again as you grow. So this is part of what you should be able to expect. So early on, bracing is a good thing. A word about bracing, remember that too much bracing causes muscle weakness. So it's very important that feet move. If you're constantly having a child tied up in braces, it shrinks up the muscle, and that's not what you want either. Too much Botox sort of fibroses the muscle. So it's complex. Everything has a complication. Everything has a risk. How about the gait? We do use Botox. It's reasonable to use it a couple times because we want to delay surgery. Rhizotomy, you hear a lot about. We are not rhizotomy proponents, but we did them in the 90s. Here's an example, again, of natural history of gait. You see this boy above. He's sort of 4, and then below, after some orthopedic surgery, and there we keep seeing him until he's 18. You have to follow him all the way through growing, because you see he developed this little foot deformity in his late teenage years. But that doesn't happen often, but can. Then we can correct it. So part of this, it has to be ongoing. It's not like one surgery and you go away, which tends to be orthopedists' approach sometimes. We'll show you, this is the kind of child who can get worse. So this boy I saw initially, we did some surgery, we got his feet flat, but above here he is now at age 12, he's growing fast, and his feet are getting flat, and I recommended that we need to do something with these feet. You can see him walking here, but then he got lost because of family situation, ended up in a wheelchair. So this is correctable if you have proper follow-up. This can be prevented, I believe. It's not part of what should just expect to happen. But there are children on the border that do tend to fall off. Spasticity management, we won't talk much about. I'll show you that you can use medicines, bracing. The baclofen pump is something we use quite a bit. You see it looks very large, but you can put it into a relatively small child, and it's not that prominent. I will just show you a little bit of the comparison of rhizotomy with orthopedic surgery. So 2 girls, about the same level of function, and the parents at this point in the 90s, I was giving them the option of either a rhizotomy or just orthopedic surgery. The girl on your right had a rhizotomy, and you see she's kind of stiff here. She's up on her toes, both of them are. And then you see, I think here we'll flip over, and she had her rhizotomy, and here she is a year later. And now her knees bend better. She's a little looser. She's still up on her toes. She's still tight. And then this girl had just therapy for a year. And we see how she's doing after a year. She's still up on her toes too. She's walking a little better as well. And then they both ended up having to have orthopedic surgery to get him down, and they both ended up having about the same orthopedic surgery. So this is this girl a year after her orthopedic surgery. And then this girl, after the rhizotomy, the rehabilitation's a little bit slower. So I just will show a little bit of this. This girl ended up doing very well, but it took her more like 2 years to recover, which is typical because you're more weak. But they both did well, and they both needed more surgery when they were in their teenage years. So it didn't really alter that. We can use a baclofen pump for kids who walk. So this is a boy at age 2. Walks like this, and then by age 5 he got stiffer and we put a baclofen pump in. So this is him with the baclofen pump. You see he looks a little looser, but he's still a bit crooked. So we then did the orthopedic surgery, and that's him at age 9. The problem with decreasing spasticity is weakness. This is a boy who was very stiff, who wanted to be able to dress himself. So we did a baclofen pump, but you can see how weak he looks. This is like 2 years after his pump. And he wanted the pump removed because he didn't like the feeling of weakness. Spasticity is not always bad. Spasticity provides a useful function. So be very careful to think that spasticity removal will make all things better. Movement disorder. So this is a boy who is not spastic, but he has this movement disorder that's very difficult. He can almost not walk anymore, so he had a baclofen pump, and here he is 2 years after his baclofen pump. The baclofen pump is the best treatment we currently have to deal with movement disorder. Thank you. It's a bit of a flying overview, and I didn't address adult issues, partly because I don't know that much, so I stayed away from it.